Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School. Welcome back to another GI Common Concerns. In my last discussion in this section, I profiled a fantastic discussion I had with one of my dear friends and mentors, former mentors, Dr. Alvin Safas at Virginia Commonwealth University, and we sat on stage and just discussed pearls, lessons learned from over 100 years of experience between the two of us. Dr. Safas had several more than myself for sure, but nonetheless, we talked about things that aren't taught in class. You don't read in books, but we've learned from experience. And I talked about esophageal pearls in the last discussion. I'll link that back to you. You can see that. If you haven't looked at that, please look back, because I think it was very valuable. And today we're going to talk about abdominal type of GI pearls, and focus on abdominal issues and gastric and more in small bowel type issues. I'll save colon for the next iteration of this. Let's talk about abdominal pain. I see this a lot. We see it all a lot. Referred by ER surgeons, rule out GI source of pain. And basically what we find a lot of times, if you're astute, is the pain is not GI pain, but it's abdominal wall pain. And a great physical exam pearl is Carnett's sign, if you've not heard of it. Something that was described back in 1926 by a surgeon. He talked about a intercostal neuralgia, basically abdominal wall myofascial pain. And this is something that you get a good history, and you may find something that precipitates why they dealt with this myofascial abdominal pain. But if not, I'll have the patient lay back, have them point to where the pain is, use my fingers to poke in that area and elicit the point of maximum tenderness, and then have them move up their shoulders in their head or lift up their legs. And that will, if it's abdominal wall pain, frequently cause a worsening of that pain, because you've changed the pressure in that abdominal area and it elicits more of a pain. And that really tells me that this is an abdominal wall pain, not a GI type pain. And I tell my patients, I'm lifting the fingers out of the abdominal wall cavity and now just on the abdominal wall. So again, they understand what we're talking about. That doesn't necessarily solve the problem, because then you have to say, well, it's not GI. What do we do about it? Well, then I'll have the patient stand up and I'll look at their shoulders and I'll look at their pelvic wings. So I'll have them stand straight, and you'll see sometimes a shoulder tilt like this, or you can look at their pelvic brim and the pelvic wings where they should be across like this, or maybe tilted a little bit like this, and tells me there's an axis shift. And this is something then I'll try and look at their spine in particular for a little bit of scoliosis. You may see this with age, and certainly it gets more pronounced, and patients become a little more kyphotic and they crouch in like this. But you've changed the abdominal wall axis and the stress on the abdominal wall muscles, changing that into a pain point. So you have to start to develop mitigation strategy around that. And I'll have them work on core strengthening, postural changes, getting their shoulders back. I'll send them to a physiatrist sometimes if it's really an ongoing issue that I can't work with. Local heat clearly is helpful. Sometimes a referral to a pain specialist for a little bit of bupivacaine or Marcaine, and with steroids. Not necessarily do that very often, but nonetheless sometimes helpful. And again, working to resolve that, but reassuring the patient that it's you don't need to go back to the ER. The costs that have been attributed to this have been in the multiple thousands of dollars. So again, look for axis shifts when you see these pain. Don't forget Carnett's sign. Abdominal pooch is one that I see it's not infrequently too. I find this particularly more in women, elderly women. I change the definition of elderly every year as I move forward in age. But nonetheless, the women will come in and they'll say, doc, I have this as abdominal pooch, and I'm not gaining weight. I'm not changing my diet at all. And I'll look at that and I'll find that most of these people are a little kyphotic. I'll have them stand up and ask if you lost some vertical height. And they answer, yes, I'm shorter by an inch or two. And I'll show them why their abdominal pooch develops. And the spine is here and your abdomen muscles are here. As you lose a little bit of vertical height, you have to distribute that forward. Anterior displacement of the abdominal wall occurs with that. So reassuring, getting core strengthening, axis to bring their shoulders back, sometimes working on strengthening things for the trapezius and deltoids to get them to bring their posture back, or how they sit and stand may resolve that. But again, reassurance, it's not ascites, in other words, and things that are more ominous, obviously intra-abdominal type of displacements or things you have to rule out for the good history and physical. Gastroparesis is something that we see, unfortunately, too frequently, in particular diabetics, but nonetheless, A diet that obviously we talk about is a low particle, low fiber, low fat diet. I generally tend to make it very simple for my patients. Soft and cooked, again, low fat, liquids if they get into trouble. In particular, we use Reglan still. Unfortunately, it's the only medicine that's approved for gastroparetic disorders. I use a Reglan Holiday when I can because of the tachyphylaxis. Recognize that tardive dyskinesia is still out there, the extrapyramidal side effects. Relative risk of tardive has been quoted in the most recent iteration, the American College Guideline, at 0.1 per 1,000 patient years. Make sure you document it in the chart. Tell the patients there are still med-legal cases out there. Domperidone is one that a lot of us use because of you don't have those side effects. Lactation, galactorrhea is a side effect. To make sure you warn patients about that. But the big one is drug-drug interactions. Domperidone can prolong the QT interval. And that is really important to remember because I think you must do a baseline EKG in these patients. A community experience report looked at this, and about 40% of patients got a baseline EKG, and a follow-up EKG was only about 25% of that 40% that after they started the medicine. When the 40% were looked at, about 15% of those patients had QT prolongation, which would be a real problem because QT prolongation in association with complex ventricular tachycardia, torsades type dysrhythmia is clearly a major issue associated with sudden cardiac death and certainly non-fatal cardiac events, which have been reported to the FDA with this medication. So routinely, you must look for the QT prolongation, but also look at cytochrome P450, 3A4 drug-drug interactions because that will prolong the clearance of domperidone. Higher levels of domperidone is associated with more of a risk for the QT prolongation. So pearl number one is get an EKG, follow up the EKG. I make the patients come back at least every 6 months and document that they know it's a non-FDA approved drug. They routinely will get it from out-of-the-country sources. There is a pathway in the FDA for an IND process, a new drug that's fairly cumbersome. I suspect most of you use out of the country. But in that sense, the pearl is also tell the patients you must call me or have your prescriber do a drug-drug interaction on an internet connectivity with domperidone, or the pharmacist, because the drug checker on most of the commercial EMRs will not pick it up because domperidone is not approved by the FDA. So it's not on a lot of the drug-drug interaction drug checkers. So be careful of this one for sure. Real quick comment about gas and bloat. We see it all the time. One of the pearls is ask about artificial sweeteners. These are insidious in a variety of diet and really even non-diet type drugs, type medications. And again, it's simple and easy to look at and remove these things. Celiac, final comment. Celiac, again, in patients that are refractory and certainly having problems, don't forget the makeup and lipstick balms that may frequently contain celiac. Soaps and shampoos can as well, but you don't get celiac unless you ingest the gluten. So you don't absorb things from your skin and scalp. But if patients are using celiac type soaps and they touch their face and their hands have soap and put that in the sense of the contact with the oral cavity. In particular, this may play out more for kids that are obviously a lot more likely to put things in their mouth. Then it may become important. But again, some of these things are a lot of hype and they don't really relate to necessarily celiac necessity for management. So GI Pearls Part 2, hopefully they're helpful, and look forward to discussing with you in another session soon. Thanks again for listening. Dr. David Johnson, I'll see you next time.